So I'm Jayanthi. I trained in Chennai 20 years ago, and we have since moved to Sydney, and I've done my FAFRM. And I used to work in public. Right now, I'm just doing private practice. I thank Dr. Venugopal and Mrilnal Joshi for giving me this opportunity. Um, I've got a presentation with a lot of information, so hopefully it'll be helpful for you guys. I'll try to brush through as much as I can in the 20 minutes that has been given to me. So, as I'm sure we all know what aphasia is. So, it's an acquired neurogenic language disorder from an injury to the brain, typically from the left hemisphere, which is the dominant in most of the people, that affects the functioning of the core elements of language network. It involves various degrees of in prime involvement depending on the four primary areas, including the spoken language expression, written expressions, spoken language comprehension, and reading comprehension. So, just to brush up the anatomy of the brain, which is going to be important for our future discussions. So, the common causes of aphasia that come across in rehab situations include stroke, be it ischemic or hemorrhagic, traumatic brain injuries, brain tumors, post-brain surgeries, and brain infections. These are the kind of adults that come across to us who will need rehab for aphasia. So I've just added some evidence for all these I've mentioned, and a few more to add on is chronic neurodegenerative disorder like Parkinson's and head and neck cancer and dementia, especially frontotemporal dementia. They all have speech problems, and we do try to help those patients when they present. So I have just added some tests that are commonly used in the Australian situation. So they use Brisbane evidence-based language testing, Mount Wilga high-level language test, and dysarthria assessment and test for apraxia. I have actually given some links in my final slides. So if you want to know more about it, you can go into that. So basically, when we get someone with speech problems, we get the speech pathologist involved as a part of the rehab team. So they do all the assessments, including the assessment for dysphagia. I understand that's going to be another topic in itself. And then aphasia, which is the language and expression, or it could be dysarthria, cerebellar or posterior circulation kind of, or dyspraxia or apraxia. And in some stuttering and voice issues, maybe in something like Parkinson's. So again, just highlighting the areas we're going to speak about, the Broca's area, Wernicke's area, and the conductive pathways, which are important. So when we come to aphasia, we always talk about fluent and non-fluent aphasias. That's the first thing we do as a part of a speech examination to find out if the patient has a fluent speech or non-fluent. So if the patient is non-fluent, then I have to decide whether it's Broca's or global aphasia. So Broca's, as we all know, the patient is able to understand most of what we say, but they're unable to express themselves. So they may be giving answers in telegraphic codes, like they might be one or two words, and there won't be any verbs. So they may have difficulty repeating in some instances. So this is commonly found when the Broca's area is affected. So this is the area that is located in the frontal part of left hemisphere of the brain, which was discovered in 1861 by the French surgeon Paul Broca, as you all know. And it is very important in the generation of articulate speech. So it's made of Brodmann's area 45 and 44. Next one is global aphasia, which, as the word is self-explanatory. This is caused when there is a massive stroke or problem affecting more than 75% of the left hemisphere, which happens to be the dominant hemisphere in most of the people. So they have difficulty understanding what we say. They can't talk or write, and they can't read or comprehend either. So it makes it very difficult. So when we are actually doing an assessment of a candidate to consider whether the patient is suitable for rehab or not. The few things we look at is whether they have a good sitting balance in the first week or so, and whether they have any aphasia. And if it is going to be global aphasia, it makes their life very difficult because they can neither understand nor comprehend and follow through. When people have global aphasia, that actually is a setback, and that is a warning that they're going to need more care, and it's going to be a different, difficult path. So, coming to the fluent aphasias, I'll just go for the more common ones. So, Wernicke's, conduction, and anomic, and I'll go into details. So, Wernicke's, as we know, is the um, area in area 22 in the posterior segment of superior temporal gyrus in the dominant hemisphere. And people actually have fluent speech, but they can't understand what we are saying, but they're always articulating. It is very difficult to repeat, and they are not aware that their speech actually doesn't make any sense. This can also commonly be seen in frontotemporal or like something like Trump speech. And the next one I'm going to talk about is conduction aphasia, which is caused by damage to parietal lobe of the brain. Again, it is characterized by intact auditory comprehension, but this and the speech production, but they're unable to repeat anything you say. So, as a part of speech examination, when you're going to ask the patient to repeat a sentence you say, so that is where the problem is, and you can actually diagnose it. So, as I'm repeating myself, so they're able to speak well. Some words may be not right. They can understand what we are saying, but they're difficult. They have difficulty in repeating what is being told. And anomic aphasias, there are a few types, but there is a word selection anomia, which may be due to the damage to the posterior inferior temporal area, or semantic anomia that's caused by angular gyrus problems. So they are again able to speak well, but they are able to understand and difficult to repeat, and they're able to find the right words. So I just thought I'll add this slide so that when we're doing a speech examination, the first thing we look at is whether it's a fluent or non-fluent, and whether they understand, if they can do yes, no answers, and if they can follow 1, 2, 3 step commands, right? Apart from that, we actually look at features of anomia, whether they have difficulty retrieving the words, and whether they are making new jargons which may be non-meaningful, almost similar to real word, but it's a jargon, or like neologisms that is not meaningful and recognizable to the listener. And sometimes they can have paraphasias, which may be phonemic, which is substituting the sounds. So for example, dishwasher may be mentioned as wish dasher, or semantic, in which they actually substitute some words. So table for bed or bird for chicken. And the telegraphic speech, as we already said, in that non-fluent aphasias, and they are not aware of their errors, and they make grammatical errors as well. And they speak either with effort or difficulty, and it can be single or fragmented phrases. So commonly in our exams, we normally play speech videos, and the person like students have to look at it, identify the problems, then go for a diagnosis, and thereby for the interventions. I'm not sure if that's the same there. I've just put some more features which we actually look at for the patients. So I don't want to go into detail. So something like difficulty understanding or comprehending, they may be able to read a big paragraph, but when you stop them to ask for the meaning, they may not be able to say anything. Or if you give non-literal language, like it's raining cats and dogs, they may literally understand the meaning and not understand what it means, and they are not aware of the errors. This is again like for people who can't write, agraphia or impairments in written expression, they have difficulty writing, typing, copying. Or if you ask them to write a sentence, they might just do a single word, or there may be incorrect letters or words, and spelling and non-meaningful syllables may be found, and grammatical errors may be found as well. And alexia is another problem where they can't identify the words by looking at it, having difficulty sounding out the words and misinterpreting the meaning of the words. For example, couch as a chair, which is close enough, but it's not the right one. And they have difficulty with articles, prepositions, and pronouns. So this is again almost the similar slide which I have discussed. So I'll move on to the next one. So we look at the interventions we do for speech and language disorders. So assessment, there are some formal and informal assessment methods. And we also ask the family and patients, like, asking how they do, because it's not always consistent. There could be a fatigue element. And then we have different therapy approaches after we identify what their problem is. And based on it, then we go for the language disorder and therapy approaches, which I'll get in detail. So the treatment techniques can be discussed in two topics. One is a restorative, which is aimed at improving or restoring the impaired function, or it's compensatory, where we can't actually restore it completely. Then we introduce compensatory strategies which can be used for deficits. So I'm sure you all are very well aware about constraint induced movement therapy. Likewise, constraint induced language therapy is also a treatment approach that is used to improve the speech while discouraging the use of compensatory communication strategies like gesturing or writing. And the patient is exclusively encouraged to use spoken language and verbalize, thereby improving their speech. Another common technique that is used is melodic intonation therapy. This is very important in patients who have global aphasia. So they cannot produce any words. So something like a song or music like happy birthday or things like that can be used. If that part of the spontaneous speech is there, then probably using some sort of expressive language, engaging the right hemisphere of pain of the brain to substitute will be really helpful. And we have other expressive language treatments, including phonological components analysis, which actually involves the following step. Am I okay for the time? I'm not sure where I am. So the words that rhymes or the words that start with, so exercises are given based on the above speeches. And there is a response elaboration training approach, which is also used by the speech therapist, where the person with aphasia responds to prompts. So it may be a picture, if you want to name, say, a house or a boat. And then the clinician reinforces and shapes, or they actually give the information about how the word starts, and then the person is given cues to take it from there. The clinician reinforces attempts to elaborate the shapes and models, and then the person attempts to repeat at the end. And there is a delayed imitation of the combined model as well. So normally in exams, like all these headings, which is actually expected for your multiple choice questions or for your point exam. So the other treatments are treatment of the underlying forms of verb network strengthening treatment and word retrieval cueing strategies. And coming to writing, CART treatment is a protocol, which is a copy and recall treatment, a protocol that uses the picture or written presentation of a word to engage spelling and then reinforcing that the spelling is through repetition. I think this is something like we do in schools where we have to write 10 times a day. Patients are given simple words and they actually initially try to draw or copy the words and then thereby building it. There are also a few reading treatments. So we encourage the patient to actually read out loud, even if it doesn't have the right sense or if they are making errors, and the family to listen. So multiple oral rereading techniques or oral reading for language and aphasia, and a supported reading comprehension techniques. These are the common reading treatments that are used. And part of the therapy for aphasia is involving the partner. That could be the spouse or family, whoever is the supportive person, or a friend. So we involve them to actually teach them for verbal and non-verbal communication strategies. We teach them how to cope, because once the patient is discharged, they need to be communicating with the family or the caring person so they understand. So they are taught a lot of strategies, including drawing, gesturing, cueing, and partner approaches. I'm not going to get into details as it is a lot of slides. So I've just put it all in there. So maybe if you guys want to read it up at the end, so I can finish the list of my slides. So Spark is one of the important things that is used as well. So supporting the partners of the people with aphasia in relationships and conversation. So that has 6 steps. So preparation, recording the conversation, preliminary viewing of the recording and transcription, then conversion assessment, and moving the assessment to training and conversion training. So this is one of the important strategies that is taught as a part of the family involvement. And then coming on to the AAC, which is augmentative and alternative communication. This seems to be very popular because finding the therapist or spending hours and hours for the treatment is difficult. So we actually look at other things that can be used for treatment. In the past, like simple like a photo or a communication book, to the high-tech devices that we have today. So when we are talking about simple things, simple hand gestures for substituting the words and trying to understand in case of significant expressive problems is used. And PACE is another common thing if you come across. So promoting FA6 communicative effectiveness. So that's the treatment designed to improve the conversational skills in people with aphasia. So it's the speech pathologist and the patient takes turn trying to convey the message or information to each other. And thereby the patient is encouraged to speak more and their vocabulary is improved. The next one that is commonly used is reciprocal scaffolding treatment. So an individual with aphasia is given an opportunity to use pre-morbid knowledge. And you can talk about the topics that they know that may be still engraved in them. And sometimes the spontaneous speech is still preserved in the patients. And visual action therapy involves the hand gestures again, which is a 12-step training. I'm not going to go into details. And these are just some tips we give for the patient and the families, right? So first of all, we try to get them into a very quiet environment. Keep your voice at a normal level and slow, simple commands. You can actually repeat the keywords. You can use gestures. But when the person is attempting to answer, we encourage to let them speak and not try to finish off in trying to get the answers. In significant difficulties, you can use yes, no answers. So I'll leave the swallowing out. So going on to augmentative and alternative communication techniques. These are just not used in aphasia alone. So in people who have difficulties like in cerebral palsy or muscular dystrophy, they also use a lot of AACs or progressive neurological decline. So, as I already mentioned, the body language movements, gestures, sign language, and communication books are the simple low tech options which is available, or using a computer or an iPad or a tablet or a smartphone with all the applications where the patient can continue to practice is also used commonly. So, I think I've already said all this. So, let me just skip it. So picture and alphabet boards are also given sometimes in the ward for person with global aphasia or significant aphasia. We have simple pictorial cards on the table, which could be like I water or wanting to go to the toilet or sleep or pain. So they are trained to use individual customized settings for the patient depending on their needs, which they can use. Again, it's the same kind of, we actually leave informations in the wards along with the charts so that anyone who takes care knows how to contact the person, how to initiate the conversation. Otherwise, the person can get really frustrated and aggressive due to lack of communication. So the speech pathologist, after examining the patient in the acute ward setting, will actually give the team information, including to the therapist and the staff, how to communicate with the patient, how to check, and to get permission. So these things are incorporated, and individualized plan is actually written up in significantly aphasic patients. So I think this is still a repetition of what I've already said, the high tech, the photographs, and most of the times, like old memories and those photographs can actually produce a positive impact on the patient, and they may be more receptive to the therapy. So we also use, voice devices or message devices as well in people with significant problems. So, voice therapy for adults can be not just because of the ones I mentioned. It could be if the patient was in ICU and they could have had damage to their vocal cords or vocal cord paralysis or traumatic brain injury with dysphonia, other than the ones already mentioned. So, people in ICU tend to have prolonged stay in ICU, tend to have a lot of problems. So I've come to the final slide, which is the cognitive communication therapy. So this is more important in people with dementia and issues, as well as like significant cognitive impairments, say post-traumatic brain injury or stroke as well. So it's very important that cognitive communication strategies are in place. And both the restorative and compensatory strategies and consistent education and support to the patient and the family are given. Just before I conclude, I've just added a few more slides just as a cheat sheet for you guys to how to differentiate aphasia and how to name it. Likewise, the summary. And I've added some reference here. And one of the things I really like is the neurological examination from Utah University, which actually has very clear examination of neurological system plus the speech in case you would like to refresh yourself. And that's the end of my presentation.
Thank you so much, ma'am, for concluding aphasia rehab on time. Actually, to be frankly speaking, we residents need aphasia rehabilitation because we are aphasic to aphasia rehabilitation. So anyone asks about us aphasia, we are just dumb. Thank you so much, ma'am. Any questions from the
I thought
audiences?
it'll be for exam purposes. That's why I've tried to include as much information as possible. And the one other thing I was thinking is because we are communicating in English, most of the things here are based in English. So I couldn't actually give a thing that is relevant locally. I hope you guys find it useful.
Actually, I am asking about spastic dysarthria. Sometimes patients are coming with dysarthria and aphasia. So
Look,
how
I
to
think it's
differentiate
based on the
between?
diagnosis that has actually gone like, more than what is the primary cause for the dysarthria than just because are we talking about aphasia or dysarthria here?
How to differentiate between both of them?
So dysarthria is the difficulty in the word production, right? Aphasia is a bit more like, it could be cerebellar dysarthria or as you said, spastic. So it could be just the motor problems, just local or like, central. Whereas this one is more the brain base, like dysphasia is more than that. So, but the therapy and management is almost the same.
What you are asking is spastic dysarthria and global aphasia. So you have to diagnose by cause only. If this spastic dysarthria, there will be spasticity in the patient itself. So that will itself cause. But compare it to stroke where you may have aphasia. So you have to first look at the cause. Then you can further manage and treat. If you have a cause related to spasticity and patient is having spastic dysarthria because of that, then it is fine. But global aphasia, like you are comparing, global aphasia, he is not able to speak any word at all. And spastic dysarthria, he is able to speak, but there will be some problem in speaking that, as you know. Thank you.
Ma'am, how do you explain a prognosis to the patient about aphasia rehabilitation?
So basically, it depends on what stage of the patient, right? Say if you're seeing the patient, are you able to hear me? You are,
Yes,
right?
ma'am. Yes, ma'am. Please continue.
So it depends. So when it comes to rehab for us, no, we may get involved in the initial phase itself. So say within the first 2 to 4 weeks, then it's still early stages, but still it depends on the intensity of the aphasia or dysphasia they have. By the time you'll also have enough information on how severe the stroke or the brain injury or the trauma that has been caused by the surgery is known to you as well, right? So based on it, we actually give an outline saying that you have this amount of disability. If it is say global aphasia, then we are very frank from the beginning, saying that this is very significant disability and it is very unlikely to change massively. So we educate and we get the patient and the family, mostly the family ready, and we still try to give rehab. It'll be more like a trial of rehab, because when someone is globally aphasic, they can neither learn nor comprehend, and taking to the next step makes it very difficult. But in the same case, say if it is a hemorrhagic bleed, right? So if you expect that it is going to improve after a few weeks, then in the initial phase itself, be honest, just tell them what to expect. And if it gets better, that's even good. But if not, we get the patient and the family ready in the beginning itself. Not that we decline the opportunity of rehab, but it's very important to be honest. And if it is a very significant disability, we need to let them know, but we'll still start. The second thing is speech is one of the things, in my opinion, is the last to recover. So speech, unlike your motor functions, like if they are starting to make improvements, it is going to be an ongoing process as well. So it's not just during your inpatient phase you're going to have it. So it's going to be an ongoing process, months, years sometimes, to continue with the rehab for that. So that is how we explain.